Good morning, everyone. Good morning, Archana, Nisha, and everyone who has joined so early in the morning. We, in the continuation of our lecture series, now today we have a very important topic, insomnia and palliative care, which we are dealing almost every day. Half of our patients says that they cannot sleep, and most of the time we are advising something or the other, but systematically how to handle this problem, I think today Anukriti will speak. I wanted that Dr. Nipun should introduce, but I can introduce both. Nipun will moderate. Dr. Nipun, he will join after some time. He is assistant professor at Mahatma Gandhi Medical College Hospital, Jaipur. Recently, they have started MD palliative medicine in their hospital. He is also done. He has also done pain fellowship in pain management as well as in palliative care. And I have seen that Nipun is very enthusiastic and very it's like very eagerly to learn more things. Plus, he is also very dedicated to develop pain and palliative care in that hospital as well as in state of Rajasthan. Anukriti is his resident, second year MD student. I can see that she has done a lot of work in COVID as well as she has done basic course in biomedical research. She has got in early age, she has got 3 international publication also. And maybe after joining this, she has developed a interest in cancer pain, palliative care, and also very good, she has got also area of interest on music and reading. Very good. So Anukriti, please go ahead, and hopefully Dr. Nipun will join. Otherwise we will take question and answer.
I'm
Yes,
here, ma'am.
so, okay, good. So Dr. Nipun is already there, so he will take up the question and answer at the end. So whatever issues or whatever question, if someone has, please write down in the chat box. Okay, go ahead, Anukriti. Start.
Sure. So very good morning to everyone who is attending this session today, and a warm regards to all the senior members from all of us at Mahatma Gandhi. Today the topic is insomnia in palliative care. So this will be the flow of my presentation. I'll be first briefly talking about sleep, the physiology and stages. And then I'll be talking about the classification of sleep disorders. So today the topic is insomnia. So we'll be talking about insomnia, what are the prevalence rates, the types, the complaints that the patients come with, what are the changes in sleep with age, the risk factors, diagnosis and evaluation, and then talking about the treatment of insomnia. So if I talk about sleep, what is sleep? Sleep is a state of suspended consciousness. It is a temporary interruption of sensory motor interaction with the environment. And the normal sleep is divided into 2 phases, the NREM sleep and the REM sleep. So NREM sleep is further divided into progressively deeper stages. The person from the awake state progresses to a deeper stage of sleep. And there are 3 stages as for now in the textbooks, but some textbooks also refer to stage 3 and stage 4. These stages, there is a sleep cycle. If I have to talk about a sleep cycle, there are 3 stages, stage 1, stage 2 and stage 3 of NREM, that is followed by the REM sleep. And after this, one cycle is complete and then the person enters into the other cycle. So if a person is taking approximately 8 hours of sleep, we can expect that there would be such 5 to 6 cycles. And from stage 1, which is a light transitional sleep where the person is drowsy, the person then enters into stage 2, which is a more stable sleep stage. And stage 3 is considered to be the deep sleep stage. And after this, the person again starts entering into a wakeful state, which is the REM sleep, which is only for the duration of 5 to 15 minutes. So NREM sleep is a parasympathetically driven state. There is parasympathetic activity. Heart rate and BP usually decreases when compared to REM sleep, where we'll see an increase in heart rate and BP. Also, muscular activity decreases in NREM sleep, and in REM phases, there is muscle atonia seen. Along with that, sometimes there's also spasms that can be seen. Arrhythmias usually occur in the NREM phase. Whenever a person is having a transition from this NREM sleep phase to the REM sleep phase, there are pulses of vagal activity. There can be asystole, there can be heart breaks, and also sometimes there are changes in posture. So BP and heart rate keep on increasing during this transition phase. Now, this diagram, we have to understand that in every stage of sleep, there are different waveforms that can be seen whenever we are trying to record an EEG of a person. So, in the wakeful state, when a patient or a person is completely awake and alert, usually we see beta brain waves. And then when the person starts entering into a drowsy state, the beta brainwave pattern converts into alpha brainwave pattern. In the stage 1 of NREM sleep, there are alpha and theta brain waves. And classically in the stage 2 of NREM sleep, we will see sleep spindles and we will see K complex. And then further down in stage 3, we'll see theta and delta brain waves. Now, this particular duration from the awake state, then the person enters into the NREM sleep. So the NREM sleep stage 1, 2, and 3 would be 50 to 90 minutes approximately. And then the REM sleep pattern is 5 to 15 minutes. And here there are rapid eye movements that will be seen. So the total sleep time and the time that is spent in stage 3 NREM gradually decrease with age. It is important for us to understand, because if a patient who's elderly and they have come to us, we have to understand that they might have problems because the duration of sleep can be decreased, as the NREM stage 3 in such patients is usually small, so which is physiological. Sleep efficiency is not proportional to the duration of sleep. Sometimes when patients are having insomnia because they're not able to sleep well during the night, they will have frequent daytime micronaps and a shorter night sleep, and they are typical features. In palliative medicine, sleep disorders merit serious attention, and I'm sure each one of us is facing this problem whenever we see patients. So as NREM stages progress, stronger stimuli would be required to result in an awakening. Coming to the stage R of the REM sleep, there are decreased EEG amplitudes, there is muscle atonia, there is autonomic variability and rapid eye movements, as I've already told. There are two components in REM sleep. One is tonic component and the other being the phasic component. So the phasic component is a sympathetically driven state. There are distal muscle twitches, cardiorespiratory variability, and middle ear muscle activity. And in the tonic phase of REM, it is a parasympathetically driven state. No eye movements are seen, decreased EEG amplitude, and atonia is there. The REM period length and the density of eye movements will increase throughout the sleep cycle. Now, the signs of REM sleep: there is a faster heartbeat, levels of BP, blood pressure are high, irregular and shallow fast breathing occurs, fluctuations in body temperature, brain activity that resembles the waking state, and this increased uptake oxygen in the brain. So this is the international classification of sleep disorders. There are various sleep disorders based on what is causing the particular sleep disorder, but we are specifically today talking about insomnia. There are other sleep related disorders which can be due to breathing disabilities. There can be central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, where there is irregular sleep-wake rhythm or delayed sleep-wake phase disorder. There are sleep-related movement disorders, restless leg syndrome. I'll be covering periodic limb movement disorder, and parasomnias, which is NREM and REM related, where there are sleep terrors and nightmares. So we'll be focusing on insomnia today. Now, coming to what is insomnia. So insomnia, very simply put, is a condition of impaired sleep, where there are difficulties in initiating sleep, or there are difficulties in maintaining sleep. Along with that, there is an experience where sleep is non-restorative and unrefreshing, despite having an appropriate opportunity for the sleep to occur. Because of this, there is an impairment in the daytime function, which the patients usually complain of. It is a complex entity, and it is a very common complaint of the terminally ill, and even other patients who are coming, even in the OPDs, I think. Insomnia can be an associated symptom of many other conditions. We will be discussing about all these conditions in the slides further. Insomnia is a very common medical complaint in primary care patients, and also it is true for patients in palliative care. And the studies that have been done illustrate that prevalence of insomnia is over 60%, if you have to say. Insomnia is a strong predictor of development of psychiatric disorders. Now, they basically, if a person is having insomnia, they can further develop psychiatric disorders, and if a patient has psychiatric disorders, it can result into insomnia. So it's a vice versa thing. Patients who are receiving palliative care may vary in terms of their functional status and where they are in their personal trajectory. So what we have to understand is that every time we're trying to give a treatment of insomnia, we have to look at a person as an individual, and a customized treatment has to be given. It cannot be generalized to everybody. We have to see where the patient is in their particular disease, and then we have to accordingly plan a treatment. It should be adjusted as per need of each patient. So we have to see that benefits are always outweighing the risk. For the prevalence of insomnia, if you have to see the difficulty getting off to sleep, it was seen that in elderly population more than 65 years, it was 28%. For patients with interrupted sleep, it was found that males were 23% and females were 28%. And patients with early morning awakening, it was 14%. And in general, if you have to see chronic pain and cancer, the prevalence of insomnia is said to be approximately 40 to 50%. So this was a systematic review of the prevalence predictors and treatment of insomnia that was done in palliative care. And it was found that prevalence of insomnia is high, with at least every 1 in 3 patients who is affected in most of the studies. So it's quite high, the rates are quite high. Another study done, sleep disturbances in patients with advanced cancer in different palliative care settings. Again, it was found that more than 60% of palliative care patients have relevant sleep disturbances. So insomnia is a prevalent problem. Now, coming to the types of insomnia, we have short-term or acute insomnia, and the duration of this being less than 3 months. And then we have chronic insomnia, where the duration is 3 months or more. So short-term insomnia, which is also referred to as adjustment insomnia or acute insomnia, this lasts for a few days or weeks, and it occurs in response to an identifiable stressor. If we are able to identify a stressor and we are able to work on it, sometimes we can easily revert this situation. Symptoms are present for less than 3 months. Now, these stressors can be physical as a part of disease. They can be psychological, physiological, psychosocial, and interpersonal. And if these sleep problems are persisting, then this person can enter into chronic insomnia states. So chronic insomnia, the symptoms that occur at least 3 times per week, or if it is persisting for at least 3 months or more. And this is associated with physiological activation, even in the absence of a comorbid medical or psychiatric condition. So these are the clinical complaints that I think everybody can relate to, that the patients usually come with. They will either come and they say that there is difficulty falling asleep, and they'll complain that they keep waking up during the night. Sometimes patients have complaints of waking up too early. There will be daytime tiredness and sleepiness as a result of this. Patients are irritable, depression is there, anxiety can develop. There are attention, concentration, or memory problems, reduced motivation, energy, or initiative. And such patients are prone to errors or accidents. And they always have concerns about the sleep. They're always dissatisfied with the sleep pattern. So this is something that I've already talked about previously. Also, we have to understand one thing. On the x-axis, there is age, and on the y-axis, we have the time in minutes. So as the age progresses, in old age individuals, the slow wave sleep pattern, which is the NREM stage 3, usually keeps decreasing. So such patients overall will have a decreased time in the sleep cycle, and this is physiological, and this has to be kept in mind whenever we are dealing with an elderly individual. Coming to the risk factors, the first being the old age. Second, if a patient already has a previous episode of insomnia, if they have a family history of insomnia, if there is a predisposition towards easy arousal from sleep. So such things have to be asked for. If they're already present, these can be causing insomnia. Apart from that, psychiatric disorders, pain as a part of disease, certain medical conditions that I'll be talking about in detail, medication and substances that a patient might be on, associated sleep disorders that are present, hospitalization, which is a very important factor that has to be kept in mind, and we'll discuss in the future slides, because in palliative care or in cancer or many other terminally ill patients, they have frequency of hospitalization increased. So that and environmental factors. Now, coming to psychiatric disorders, chronic insomnia and psychiatric disorders will often coexist, and half the patients with chronic insomnia have psychiatric disorders and vice versa. So, insomnia mostly said that it precedes a psychiatric illness or the development of psychiatric illness. And certain studies have been done. They suggest that any individual who's having insomnia, they are at an increased risk of developing new psychiatric disorders within 1 year when we compare it to that individual who's not having insomnia. So psychiatric disorders mainly that we see would be anxiety, depression, and certain substance use disorders that mostly cause insomnia in patients. Now, depression, insomnia, whenever coexisting with depressed mood or loss of interest or pleasure, is a diagnostic symptom of unipolar major depression. There are 40% of people with insomnia who are having clinical depression, and 80% people who are having depression that report insomnia. So these two entities go together. Early morning awakening is always a hallmark symptom of depression. So we can always ask in the history if the patient is having such a problem. Depression is variably associated with a reduced latency to REM sleep. Coming to anxiety, anxiety disorders share diagnostic overlap with insomnia. In anxiety disorders like generalized anxiety disorder or post-traumatic stress disorders can have cause increased subjective sleep disturbance, a decrease in total sleep time, and decreased sleep continuity. And insomnia can be before, it can be at the same time, or even after the onset of anxiety. And whenever we are dealing with palliative care patients, it is seen that mostly such patients with insomnia, usually when they give a history, they'll describe anxious and negative ruminations. And they can be, anxiety can be about various aspects of their disease, what is the future for them, and they always have a certain fear of suffering and death, and that keeps causing anxiety. Super added to it, once the insomnia develops, they're always anxious if they will get sleep in the night. So that also adds up. Coming to substance use disorders, a very common thing among patients with substance use disorders across a variety of substance and the stages of illness. It predates alcohol dependency in the majority of patients with alcohol use disorders. And also it is an important risk factors for relapse to drinking among those who have achieved abstinence, because once they're not getting sleep, they try to go back to their habits so that they can get sleep. Medical conditions, insomnia follows a chronic course, and this can be comorbid with a medical illness or any medications that are being given to treat that particular medical illness. 10% of patients with insomnia that is lasting more than 1 month have a coexisting medical condition, and 40% of patients who are having a medical problem have insomnia that is in a chronic course. So these are the medical conditions that mostly result into insomnia. Pulmonary disease, mostly COPD, it is seen as a chronic state. Hypertension, diabetes, cancer, heart failure, neurological disorders, mostly Parkinson's and Alzheimer's, and certain other factors, that is medications again that are being given to treat the medical conditions. So antidepressants, glucocorticoids, beta blockers, opioids, and other thing being the restless leg syndrome, and also most importantly hospitalization as a result of the medical illness. So another study was done, sleeping related distress in a palliative care population, and it was found that there is a high prevalence of sleeping related distress, and the associations were very strong because the distress was due to pain, breathlessness, and fatigue. So such symptoms also result in a patient entering into insomnia. We have to encounter these symptoms also, and we have to acknowledge and treat. Coming to hypertension, hypertension and insomnia frequently co-occur. Patients who are having chronic insomnia have an increased systolic and a diastolic BP during their sleep. Insomnia with and without decreased total sleep time have been associated with an increased risk of hypertension as well as cardiovascular disease. So this has to be kept in mind. Now, diabetes, it is seen that half of the patients who are having diabetes report insomnia, and it can be as a result of diabetic neuropathy if a patient is in that state where they have developed diabetic neuropathy. Also, studies were done and they suggest that there is a reduced objective total sleep time, which was an independent risk factor for diabetes. What happens is that whenever there is sleep loss, it starts affecting the insulin resistance. There is altered glucose metabolism, and as a result of this, there is a glucose control that is affected. It can be in diabetics also and in non-diabetics also, and even they are predisposed to diabetes. Coming to cancer, prevalence of insomnia in patients with cancer is 50 to 70%, and the contributing factors here can be pain as a result of cancer, all the other associated physical symptoms. The treatments that are offered are vigorous, and there are certain many side effects that patients face, the emotional distress associated, the psychiatric comorbidities, and also the frequent hospitalizations that the patients have to go through. Pulmonary disease, 30 to 70% of patients with pulmonary disease report insomnia. COPD symptoms and the frequency of the exacerbations are related to the severity of insomnia. What happens in such patients? When they lie down, there is an increased work of breathing. Secretions start pooling in the airways. So as a result of this, they have a difficulty in breathing. There is nocturnal bronchoconstriction, and as a result of this dyspnea, they are not able to sleep well. Insomnia may also be due to respiratory stimulant medication or glucocorticoids that are being given to treat these problems. Chronic pain. So pain is the most common cause of both acute and chronic insomnia. It is quite understood that with pain, it is always difficult to sleep. And 75% of patients who are having chronic pain have insomnia symptoms. Even short-term treatment of insomnia can be associated with long-term improvement in sleep, chronic pain, and fatigue. The sources of pain that may disrupt sleep can be gastroesophageal, headache, musculoskeletal, or neuropathic. Insomnia in chronic musculoskeletal pain, widespread pain, the pain is widespread. There are physical limitations that come along with it, and also there is a reduced social participation, and all these things add up to the stress and anxiety factor resulting into insomnia. The management of pain is the primary method to improve sleep. So instead of just trying to treat the insomnia, if we are managing the pain well, it's possible that the patient might be able to sleep well. And all the medications that we are trying to give towards sleep should be reserved till that time, and we should focus on maximum pain control. And until the maximum pain control is established, we must try to hold on to the medications that are directed towards sleep. Sleeplessness most likely increases pain intensity and frequency. Patients with heart failure, 30% of patients with heart failure may have insomnia. It can be related to shunt strokes, breathing. There can be frequent awakenings that is due to nocturia because diuretics are being used in such patients, and this can also lead to insomnia. Insomnia and frequent awakenings have also been associated with an increased risk of atrial fibrillation. Neurological disorders, insomnia is common in patients with neurological disease. Those patients who are having Parkinson's disease, it is seen that 80% report sleep disturbance. And patients who are having insomnia are also at an increased risk for development of dementia. Among those patients with Alzheimer's disease dementia, 25% have insomnia. And a continuing insomnia due to increased stage 1 sleep and awakenings may be related to nocturnal agitation, delirium, and wandering in such patients. Parkinson's disease and Alzheimer's disease, insomnia is very common in Parkinson's disease due to primary motor symptoms of tremor, bradykinesia, and rigidity. Also, non-motor symptoms such as depression, hallucinations, and nocturia can also contribute. In patients with renal failure, insomnia is highly prevalent in patients with chronic kidney disease. Contributing factors can be pruritus, pain, nocturnal leg cramps, sleep apnea, and circadian rhythm alterations. Optimization of renal replacement therapy is important in end-stage kidney disease. Restless leg syndrome. Uh, Such patients with restless leg syndrome usually describe it as a creeping, crawling, itching, or a sensation of jitteriness in the legs. And we can always ask the patient while we are trying to take a history if they have a certain discomfort in their legs at night, because it is usually increased in the evenings at night. And just by asking this question, it is possible that we might be able to screen a patient for restless leg syndrome and might be able to help. 85% of patients with restless leg syndrome have difficulty for falling asleep. Coming to medications and substances that can be given during the course of all the illness that I've discussed, the medical conditions that I've discussed, certain CNS stimulants, caffeine, methylphenidate, amphetamine, and modafinil. The usage of these medications can result in insomnia. Respiratory stimulants such as theophylline, appetite suppressants, liraglutide, phentermine, bupropion, alcohol, tobacco withdrawal states, especially in a cancer setting, patients who are on alcohol or tobacco and they land up into cancer, and suddenly there is a cessation of these things, and because of the withdrawal states they start complaining of insomnia. Nasal decongestants, beta blockers like propranolol, metoprolol, pindolol. So we can always take a history if patient is on these drugs. Coming to antidepressants, monoamine oxidase inhibitor antidepressants, phenylizine, selective serotonin reuptake inhibitor, fluoxetine, norepinephrine and dopamine reuptake inhibitors, bupropion, which is also appetite suppressant, serotonin and norepinephrine reuptake inhibitors, venlafaxine, and tricyclic antidepressants, protriptyline. Glucocorticoids, I already discussed about glucocorticoid that can be given in respiratory disorders. So prednisone and dexamethasone are associated with an increased wakefulness during the night. Now they cause a decrease in the melatonin levels in serum. And also it is seen that insomnia can occur in 50 to 70% of patients who are on prednisone, and because it reduces the cortisol level, and this cortisol is basically responsible for maintaining the diurnal rhythm. So because this diurnal rhythm is disturbed, patients who are on prednisone can land up into state of insomnia. Patients who are on oral and inhaled glucocorticoids commonly produce insomnia. If we lower the dose and if we are administering the medications early in the day, this can attenuate the sleep disturbances. So in such patients, we can try and do that. Opioids, now usually opioids are sedating, but if chronic use is there, sometimes that results in sleep fragmentation and an increased nocturnal awakening. And this overall changes the sleep architecture, and because of which sometimes the patient can have insomnia. Polysomnography may be required for diagnosing sleep disordered breathing due to chronic opioids, and the treatment would be lowering the dose and positive airway pressure therapy. Hospitalization it's an important factor. Patients who are in palliative care, patients who are terminally ill, or patients in cancer, these people have a frequent hospitalization. And what causes trouble, what causes insomnia is that there is sleep disturbance in the hospital that is multifactorial. First is the environment. So we have to, whenever we are trying to approach the treatment, we have to optimize the sleep environment. And along with it, as I have already discussed the medical condition, the medical illness and the symptoms that are following the medical illness. So we have to focus on treating the medical illness. Along with that, we have to make sure that the sleep environment is optimized. Minimizing any stimulating or sleep-related side effects of concomitant medication is equally important. So everything has to be managed all together. Now, patients who are in an ICU setting, they have significant alterations in their sleep architecture. Their sleep becomes highly fragmented. They can be frequent arousals. They can be poor nocturnal sleep efficiency. And there is an increase in stage 2 NREM sleep. Stage 3 NREM sleep, which is the slow wave sleep, there is a reduction or even an absence of this particular phase, and there is reduction or absence of REM sleep. Circadian rhythms can be altered during hospitalization, especially in patients who are in ICU, and average sleep duration over 24-hour period may be reduced during hospitalization. So what is the problem in the hospital setting or in the ICU setting? The noise in the hospital. Now, where it is coming from, it can be various sources. It can be the equipments, it can be the machines in the ICU. And along with that, there is a constant patient care interaction that keeps happening. We are taking vital signs, we are drawing the blood, there can be diagnostic testing. This results in poor sleep in patients who are hospitalized. Studies that were done using polysomnography in the ICU found that 10 to 20% of the arousals can only be attributed to noise. Patients in ICU often report in nocturnal light exposure because of constant light. The lights are never out in the hospital setting, because of which there is a disruption in sleep. So light and noise, along with the illness and all other factors, the medications and symptoms can cause insomnia. Coming to the diagnosis and evaluation of insomnia, there is a diagnostic criteria according to the ICSD-3, and if this criteria is matching, the person is said to have insomnia. First, difficulty in initiating sleep, then maintaining sleep, or the waking up too early, which were also the clinical complaints that we have talked about. Sleep difficulties despite an adequate opportunity to sleep or an adequate circumstance for sleep. As a result of this, daytime impairment, which is attributable to sleep difficulties, and this sleep wake difficulty not being explained by any other sleep disorder. So if we ask about all these four things and if these criteria are matching, the person has insomnia. Now, this is a diagnostic criteria, and I have already covered all of it, but it is a compiled diagnostic criteria. And again, the same thing, there are 6 criteria, 6 points that we have to look into. First, again, as I've already discussed in point A, point B, if the patient complains of fatigue, attention, concentration impairment, if there are impaired social, family, occupational, other problems, mood disturbances, daytime sleepiness, reduced motivation, behavioral problems, proneness to errors, that this is also something I've already talked about. And then a person getting sleep less than 3 times per week, and also symptoms that are present for more than 3 months. So this is mostly for chronic insomnia. These things have to be taken into account, and this becomes a diagnostic criteria. Now, how do we evaluate a patient for insomnia? It is a clinical diagnosis that will be established by history and patient report. So there can be a sleep history that we can take, and we can ask the patient to maintain a diary, detailed description of the sleep problems, what are the number of awakenings, what is the duration, the sleep time, when are they going to bedtime, what is the duration until their sleep onset, how many naps they take during the day, what are the lengths, and any other symptom that is associated that can be causing disturbed sleep, and how is the sleep environment. We have to ask about that. Along with that, patient should be asked to maintain a sleep diary, so to record sleep time, the problems. So this is a sleep diary. This is how it looks like. This can be given to the patient, or this basically keeps a record of when they go to bed and how much time it takes for them to sleep, and when they get out of the bed, what is the total hours of sleep and the quality of sleep, if there's drowsiness in the day. And this is like a weekly thing. So based on this, we can not only just evaluate, and we can also treat better. Now, this is a Pittsburgh Sleep Index. This is also this is like a form we can give it to the patient, and again there is a questionnaire when they are going to bed. Again, the same things: how much time it takes for them to fall asleep, and what was the how many hours of actual sleep were there. There is a numbering that we do, and it is usually said that if out of 21, if the score comes out to be 5, then it is poor sleep state and insomnia. Another, the Epworth sleeping scale. So this is a modified Epworth sleeping scale, and again we have to scale based on these 8 factors: sitting and reading, watching TV, if they're sitting in a public place, sitting in a car, lying down to rest, sitting and talking to somebody, and there's a score of 0, 1, 2, and 3. And based on that, we can always evaluate the maximum score being 24. And if the person is having a score of 10, this will suggest presence of excessive sleepiness. This is a generalized anxiety disorder, 7 anxiety scale, and we have to assess the anxiety states in certain patients who might be having anxiety, and as a result of which they have insomnia. So if they have nervousness, if they're not able to control their worrying, if they cannot relax better, and there is a score again 0, 1, 2, and 3, and based on this, we can evaluate the patient. The additional testings being polysomnography, home sleep apnea test, and actigraphy. Now, polysomnography, so these are sleep studies, and mostly polysomnography is a lab-based study, usually done at night, and mostly for obstructive sleep apnea. It is helpful, and it is a diagnostic tool in sleep medicine, if I have to see. And we obtain a polysomnogram, and it is very helpful in in the diagnosis of sleep disorders. It will record the brain waves, the heart rate, the breathing patterns, the oxygen in blood and brain, and the eye and leg movements that are occurring during the sleep. Home sleep apnea test is a kind of polysomnography thing, but it is done at home. It can be done at home. There is a portable device that we can attach to the patient, and it will monitor overnight activity. Again, parameters being the respiratory activity, there can be breathing patterns recorded, chest motions, heart rate and blood oxygen levels, sleep position and the changes in position, and if there are any snoring events or intensity. So this is a little more convenient, but if we have to say, polysomnography is more accurate. Actigraphy, it's a validated method of objective measuring of sleep, and there are parameters that can record the motor activity over a period of days or weeks. And this is again a non-invasive accelerometer, like a wristwatch that we can attach to patient's wrist, and we can record. So these are helpful in diagnosing of insomnia. And coming to the treatment part, they can be pharmacological and they can be non-pharmacological modalities that we can use to treat insomnia. So whenever sleep disorders are secondary to medical or psychiatric conditions, the treatment should be directed at the cause. Once the treatment begins, we have to continuously reevaluate. And then it's seen that the recent guidelines suggest treatment should be initiated with either a short-acting or intermediate-acting benzodiazepine receptor agonist as a first line. In case of those patients with depressive disorders, if there is a depressive disorder underlying, a sedative antidepressant can also be used. The first line drugs, if they are ineffective, then antidepressants can be considered as the second line. The non-pharmacological modalities are cognitive behavioral therapy and sleep hygiene measures mainly. And then there are other factors like patient can be taught to exercise, relax in certain ways, but these two being the mainstay. For pharmacological, we have benzodiazepines, sedative antidepressants, melatonin, and others which are antihistaminics, pregabalin, and antipsychotic drugs. So this is a diagram that depicts that there are certain factors that influence sleep. There is brain homeostasis and circadian clock, one which promotes wakefulness and the other system that promotes sleep. So all the drugs that we are trying to give have different actions. Like if I talk about caffeine, psychostimulants, they're mostly wakefulness promoting system acting drugs. So they are mostly directing that. There is another drug, orexin, which is working on the lateral hypothalamus, again would be affecting the ascending arousal system, where there are many neurotransmitters, norepinephrine, 5-HT, acetylcholine. The drugs that we are talking about, that is benzodiazepines, these are GABA mimetics, selectively increasing inhibition of the wakeful promoting system. So what these drugs will do is they will act here and they will try to inhibit the wakefulness. There are other drugs that are amitriptyline, doxepin, mirtazapine, hydroxyzine, and these agonists block the ascending arousal system's target receptors, mostly at the cerebral cortex. So these drugs are going to promote sleep. Coming to benzodiazepine receptor agonists, which are the first line drugs that are preferred. There is zolpidem, there is zaleplon and zopiclon. In the dosing of 5 to 10 milligrams can be given at night, zolpidem. Zaleplon 10 to 20 milligrams again given at night. And zopiclon 3.5 to 7 milligrams approximately can be given at night based on the patient condition and the evaluation. These are the current medications of choice. They reduce the sleep latency and wake time after the sleep onset. The side effects are usually daytime sedation, nocturnal confusion, and performance decrement. And there is no rebound insomnia or withdrawal that is seen even on long-term use. So that is a benefit with these drugs. Coming to sedative antidepressants, there is an important role they have in chronic insomnia, and these are the second line preferred drugs. Or if the benzodiazepines are not effective, contraindicated, or there is underlying depression, they can be used. Tricyclic compounds, amitriptyline, doxepin, amitriptyline 20 milligrams, doxepin 25 milligrams given once daily. These are the doses I'm telling to initiate, and then we can adjust later. Side effects: excessive sedation, orthostatic hypotension, cardiotoxicity. Melatonin, now this is a hormone that is produced by the pineal gland during the night time, during the darkness, and it is for the reinforcement of the circadian rhythm. Melatonin reduces normally as part of aging. So once the person is in elderly age group, old age, they will have reduced melatonin. Ramelton, which is a melatonin receptor agonist, also reduces latency to sleep, but it will not increase the total sleep time. And the dose of Ramelton is 8 milligrams, should be given 30 minutes before the bedtime. Other drugs, as I told, antihistaminics. This is used as sleep-inducing agent, including diphenhydramine and doxepin, given in a dose of 3 to 6 milligrams to initiate, and then we can adjust. Pregabalin 300 milligrams at night is reported to decrease insomnia and anxiety in patients with generalized anxiety disorder and insomnia. And atypical antipsychotics, quetiapine 25 milligrams is the initial starting dose BD that can be given morning and evening, and we can start adjust it for 50 milligram BD and go up to 100 milligrams. And olanzapine 5 milligram given at night time, occasionally used for insomnia. So this is a pharmacotherapy for sleep disturbances. These are all the class of drugs that can be used. Mostly highlighted the drugs that we have discussed: the non-benzodiazepine hypnotic drugs, zaleplon, zolpidem, zopiclon; antidepressant drugs, amitriptyline and doxepin; non-prescription medications, melatonin; antihistaminics, doxepin I've already discussed; alternative agents like Ramelton in place of melatonin; anticonvulsants, pregabalin, even gabapentin and tigabalin can be considered; and antipsychotics, olanzapine and quetiapine. Coming to the non-pharmacological interventions, which is cognitive and behavioral therapy, sleep hygiene practice, which is a very important aspect of management of insomnia, exercise, expressive therapy, and complementary and alternative medicine. So cognitive and behavioral therapy. Now this picture that I've put, it basically, this is a cognition. A person has a certain thought. A person might have a thought, a fear. What if I'm not able to sleep? What if I'm not able to wake up next morning? Then there are certain emotions. There is an emotion of fear that sets in. Because of that, he starts overthinking, and now he's not able to sleep. And as a result of it, there are certain physical sensations that start entering. If there is pain, it becomes enhanced. If there is any other symptom they are facing, dyspnea is there, it becomes enhanced. And this becomes a cycle. So we have to break this cycle. CBT is an integration of cognitive therapy and behavioral modifications. This is effective for both treatment and prevention of relapse of insomnia. Patients who are having higher levels of comorbid pain and insomnia usually benefit from CBT interventions. And the only thing is, it requires an active participation by the patient. So patient has to help us if we are trying to give cognitive and behavioral therapy. Patients will learn specific techniques such as relaxation training. And if this is employed in pre-sleep period, it will prevent the cognitive and physiological mechanism that initiate and sustain insomnia. And it is by the American Academy of Sleep Medicine recommended as a standard treatment. Benefits of CBT being improved sleep parameters and a reduce in medication use. The sleep hygiene measures, which are very important, that we must know, and that we must try to always tell the patients who are coming to us. We have to tell them that first of all, we have to make sure that the sleep expectations are realistic. The normal sleep duration is 6 to 10 hours per night, so that is important. And 1 to 2 awakening per night is normal. So this, whenever a patient or the attendant is coming to us, we have to counsel them over this. We have to try to make them understand it's better to always wake up at the same time each day. Very importantly, in bedroom, it should only be used for sleep. There should not be any other activity using having a TV, television, and watching television, using a laptop, any other gadgets, because that kind of activates our brain, that kind of arouses, and because of that, we cannot get sleep on the right time. Napping in patients who are at home also, and in the hospital setting, we must try that they're not having multiple naps, because they sleep during the daytime and then they're not able to sleep at night. Especially naps should be avoided in the evening, because after 3 to 4 p.m. if these patients are having naps, then they'll have a difficulty sleeping at night. And most important thing that we have talked about in hospitalization also, the light and noise have to be ambient. If we are not able to provide that, at least we can try considering the use of eye mask or earplugs, so they are able to sleep well. What are the adverse outcomes of insomnia in a totality? So chronic insomnia has an adverse impact on daytime function and the quality of life. Insomnia with objective short sleep duration is associated with increased cardiovascular risk and mortality. There is increased fatigue, sleepiness, confusion, tension, anxiety, and depression. There's a decrement in both emotional and medical aspects of life, increased risk of substance abuse, that is following the over-the-counter drugs, and an increased risk of suicide, increased risk of hypertension, myocardial infarction, and other cardiovascular problems. And as I've discussed, due to increased insulin resistance and an increased risk of diabetes and its complications. So we must understand, we must know that sleep is an essential part of life, but more importantly, it's a gift. Not everybody has it. People have lots of sleep problems, and we are lucky if we are getting sleep. These are my references. Thank you.
Thank you, Anukriti. Very good presentation.
Thank you, sir.
I think we have covered all the topics, right from etiology to risk factors to mechanism to evaluation and diagnosis, and then management of insomnia.
Yes.
Any questions from anyone?
Ma'am, can I stop sharing? Archana, ma'am?
Yes, you
Yes,
stop
sure.
sharing so that people will be on the stream. Yes. So anyone wants? Have you handled this? How long to continue the medications?
Ma'am, usually we monitor always that how long we have to continue. But in our setting, usually as we are getting patients in a very later stage, so there are very less instances when we are able to withdraw them. Mostly once we are continuing them, they continue for 2 months, 3 months, 4 months, or as long as the patient is survival. We need to continue them very often.
Anyone wants to ask anything?
Yes, I would like to ask, please. It's Julie Byrne here.
Hi, Jibu. How are you?
I'm fine, thank you very much.
Yes, please go ahead.
Wonderful presentation. Thank you so very much indeed. I've spent about 10 years of my life on night duty, and there's a really important role of the nurse here. And I was really glad to hear you talk about sleep hygiene. But sleep hygiene is something that doesn't seem to happen in hospitals, number one. Number two, how we all sleep, don't we, in the most comfortable place with our pillows on our sides. How do patients manage to sleep when they're tied to the bed by their fingers and their legs in the intensive care? I just wonder how that, what that does to people's sleep.
Ma'am, it's very difficult for patients to sleep in this condition, but usually in ICUs, I think specifically you're referring to when the patient is tied to bed. But usually they're very agitated in those conditions, because I have myself worked in ICU for a very long time. And once a patient is agitated and he is about to harm himself, yes, his sleep will be disturbed, definitely. But if he's tied to bed, there must be some reason behind it. The patient must be agitated. He might get violent or removes his IV cannulas or tubings, whatever. So it's all situational, ma'am. We have to work out for the best in the given circumstance. Yes, it is hard on patients. Yes, it is difficult on patients. But sometimes we have to do what is necessary. But yes, it affects the sleep of person, and we should try to do it as less as possible.
Yeah, I mean, I think I have serious concerns about the tying of the patients, because it's obviously very, very dangerous practice.
Yes,
But I'm
it's
wondering,
really bad.
can we be thinking outside of the box now in intensive care units, getting maybe the relative to sit with the person, to help them, to calm them down, to massage them, to hold their hand, to speak gently to them, because the nurses are obviously terribly busy and they haven't got time for that. When I was a night sister, so I worked on night duty, as I say, for about 10 years of my life, I had the time and the luxury to sit and talk and listen to the patients. And one of the things that I've observed both in the community in India and in your hospitals is that the people that are awake, when you say to them, what stops you from sleeping? It's worry. So we have to address then the worry. And I'm remembering a man who said, I said, what are you worried about? Because that's what we need to hear. He said, I'm worried I won't see my daughter married before I die. No amount of drugs is going to help that. So what we did is we brought in the family. I told his daughter, who was 26, your papa loves you very much, and he wants to find a husband for you. And the family had had this collusion and a conspiracy of silence. The man knew he was dying. He was being treated at Tata Memorial Hospital for 6 weeks, and everybody said, don't tell him he's got cancer. So when he wanted to go to Jehu Beach to walk, and he wanted a peg of whiskey at night. And actually the next morning he'd had his peg of whiskey, he'd been to Jehu Beach, and he'd started looking for a husband for his daughter, and he had his first night's sleep. So I think we have to look at the very simple things. And this is where nurses need to be asking the patients, what keeps you awake at night? And I think we'll find it's worry. And those are the things that we need to address. And we need much more teamwork, with nurses being much more proactive in the sleep hygiene sense of things.
Thank you, Julie. I think this is an important comment. Definitely, tying hands and legs in the ICU is not a good practice.
Not good.
Everyone should try that. This practice should not be followed. And uncertainty about the diagnosis, prognosis, and about the disease is the most important cause, which we have also studied in our ward.
Yes.
What is the most important cause of sleeplessness? So uncertainty makes a huge difference. If you will make them understand about the disease status and the treatment plan, and what is the realistic hope possible from the treatment, I think it makes a huge difference. So it is an important aspect. So thank you, Julie. So there are good questions. Nipun, if you want to take up one by one, the Dr. Sanjeev is asking, how does cytokines affect sleep patterns? Are there pro-sleep cytokines?
Ma'am, I'm not aware of them. I will be very honest. How do they affect? So I'll get to it and I'll let you know.
Sanjeev, do you know about this? Sanjeev, you have asked this question? What is the
yes, ma'am. Because there are multiple cytokines that are responsible for development of fatigue. So that is the reason I was asking whether these cytokines are involved in insomnia or not.
So fatigue has a direct relationship with the insomnia, but because if anyone can answer this question, or otherwise we can go to the next. And Anukriti, you should read this and let it Sanjeev know.
Yes, ma'am. Because ma'am, actually on the literature that we have, they say that certain cytokines promote sleep and certain cytokines can be responsible for insomnia. So we have to read in detail, like what are pro sleep and what can cause insomnia, I think, and then get back to sir on this.
Okay.
Yes, ma'am.
Dr. Jennifer, do you have any answer on this?
Nothing specific, ma'am.
Not specific. Okay. So I think we can read it and
then get back to you.
Anukriti, please send this answer.
Yes, yes.
Maksuda from Bangladesh. You know, the Bangladesh participants, the MD students are also joining our classes. So Maksuda is asking, how about diazepam and clonazepam? Can they reduce sleep latency? Are they good to use for insomnia? This is an answer which Nipun can give.
Yes, ma'am. Diazepam and clonazepam, they can be used. They're already being used in a variety of settings, and they can reduce sleep latency, and they can be used for treatment of insomnia as well. It was given in our chart also, along with dosage and everything. We can use them.
Dr. Vinay Somaya is from Shimla. He is asking, can Z drugs be given to COPD drugs?
Can?
The
Vinay,
benzodiazepine.
what do you want to ask, please? Can you open your mic and tell, Vinay?
Good morning, ma'am.
Good morning. Yes.
Can that drugs can be given to the COPD patients, ma'am?
Which
Because
drugs?
they have
Which drug?
that drugs.
Benzodiazepines, the zolpidem and all.
Yes, yes,
We can
already,
use
yeah. Because COPD patients are also anxious. We can give. Yeah, this
Yes,
is
we can use all the.
recommended.
Okay, ma'am.
Yes.
We can use the
Thank you.
drugs. Just we have to see the patient condition always, and accordingly we can use them.
Dr. Meenakshi, I will take your question at the end. Let me read all other questions. So there are no more questions. So anyone wants to say the practical tips when using Z drugs? Dr. Meenakshi wants to ask. I think for giving practical tips, we will ask one by one our senior people, those who have joined. So first again, Dr. Jennifer, what are the practical tips on using Z drugs? Dr. Meenakshi wants to ask. And Dr. Stanley, after that.
Yeah, thank you for that very comprehensive presentation. Before I answer that question,
Thank you, ma'am.
so
Thank you.
one of the things that we need to keep a practical suggestion is, like any symptom, we need to find out what is the cause. I think this was again Diliban had mentioned. We should not jump into giving a medicine for medication for insomnia without identifying the cause and without using non-pharmacological measures and treating the cause of insomnia. So Z drugs, yes, they can be used, but you should be careful when you are using other medications which might also cause respiratory depression. You should look out for substance abuse or risk of addiction, because these drugs, when they are used long term, then again, when you really need to stop, and if they have been started when they were not really necessary, then that becomes a problem. So I think you need to choose the right group of people and see if you can use it for the shortest duration possible.
Definitely,
Thank
ma'am.
you,
It should
Doctor.
go
Thank
in
you,
our
Dr.
head
Jennifer.
Thank you.
that what are the
So
patients.
we have
that
one more
we-
minute, and then we have to stop. Dr. Stanley, you want to add anything in this?
Yeah, thank you for that excellent presentation. Just a small tip. Some of our dementia patients may not express their symptoms properly, so and often musculoskeletal pain is, always there. They're lying in bed, the pain of inactivity, so to say. And so giving a small dose of paracetamol at night would seem to help that. So that's one thing. And also, as Didi mentioned about anxiety, and those are the causes, and what Jennifer also has mentioned. Thank you.
Thank you, sir. We will keep it in mind.
Okay, thank you very much. So we have now it's 7:30. We have to stop here because it's a working day. Thank you, Nipun, and thank you, Anukriti.
Thank you very much.
Anukriti.
Thank you very much, ma'am, for giving us the opportunity.
Yes, this was, and she has presented it well. I'm so happy that Mahatma Gandhi's students are smart, and
Ma'am,
she
she
has
is very
given a
good,
very
ma'am, and
comprehensive presentation on insomnia. So
yes,
thank you, Jiliban. So nice to see you.
thank you, ma'am.
Thank you, Dr. Jennifer, Dr. Stanley, and thank you everyone for joining early in the morning. And thank you participants from Bangladesh. They are also participating and they are asking questions and they are active. If I forget to send the link, they asked immediately at 10 o'clock in the night that you have not sent us the link. So today I will give the address to Sir Archana. So this responsibility I will pass it to Archana today. So anyway, good. Have a nice week. We will see you next week before 6:30. Okay.